So I'm actually back in the TACE game after a long time, and you know what? They're great. I work with a couple surgeons who prefer operating on post-TACE livers rather than post-Y90 livers. And so, they're the occasional case where they insist on chemoembolization, but I haven't done a combined TACE ablation in a long time. So my question for you is, how are you choosing the combined approach rather than, one or the other or Y90?
Yeah. So, we generally won't do the taste and the ablation like on the same day, obviously, but a lot of times, by the way, I will say that it is very satisfying seeing that staining, that tumor staining. It's really nice. When we do them, like, it's like, oh, shoot, that's a beautiful image. What we'll do is we'll oftentimes taste in the office, send the patient home, make sure they did okay. And then usually like within a week or so, as long as they're doing okay, maybe 2 weeks tops, we'll bring them back. And obviously we'll do it at the hospital, with anesthesia and everything. We're not that wild. We're not doing, those kinds of cases in the office. But yeah, we'll bring them back. And, a lot of it is, when you have the lapidal in, it's a lot easier with CT. I know earlier we were talking about kind of, the approach and kind of the technique. A lot of times I'll look with ultrasound too. I don't think you need it as much in terms of the ultrasound. You can definitely look, but I think that once you've got that staining of the tumor on a non-con CT, like that's an easy target in my opinion. The ultrasound is nice though, I will say, like in general, because it's real time and you can see it. And then the other thing that, I mean, this may be a little weird, but like when you hear that tumor pop, like I don't know if you've heard that too much, but it's like sometimes it's an audible, like when you hear it and it's like, oh, okay, well, we got it.
All right, so let's talk about that, how you're doing the cases. Talked about the patients in tumor board. You've seen them in clinic. You've got the case set up. What's your room set up like? I mean, do you have ultrasound in there for all the cases, or do you usually just get them set up in CT and bring in ultrasound if you need it?
Yeah, so usually we'll do it in the CT room, but I'll always have ultrasound in the room. For certain cases, it's like, it's very obvious that it's going to be a pretty much CT case. I'll still just take a quick look. I do like, all right, so the question becomes like, CT, obviously, great resolution, et cetera, but it's not real time, right? So then do you go to CT fluoro, which is a little bit more real time, or do you just go with ultrasound? I kind of like, using a combination. I'll usually start with the ultrasound and see if I can see it. Again, if it's one of those like relatively peripheral, maybe lower down in the liver, like that's kind of an easier ultrasound case. Kind of a little bit of a tougher location, maybe not the best for ultrasound. Maybe we'll take a look and say, okay, all right, we can't really see it all that well. Or maybe the ribs are in the way or something. Even with angling the ultrasound, you may have trouble. All right, so we'll do this with CT. I will generally start with a non-con CT, just obviously just a scout, put the grid over. And if you can't see it, then I might give some contrast just to really make sure. So sometimes when it's hard to see, and I don't love doing it this way, but sometimes you have to, just relying a little bit on landmarks.
It's kind of shocking the number of cases where I get in there, scan with CT and can't see the lesion at all. It stuns me how frequently it happens, both in the kidney and in the liver, sometimes even after giving contrast, especially talking about small metastases. Sometimes you can't even see with ultrasound. And I think you've just got to get really good at triangulating. It's something I use in really every case, but you got to be able to measure from, this little portal venous branch or this hepatic vein and go from there. And it's a pain in the ass, but it's reliable.
Yeah, that's so true. Some of these are just going to be hard to see and you just have to just rely on landmarks. I always keep the image up on a second computer, like kind of right in the control room. So whether it's MR or CT, it's interesting, right? Like I kind of prefer having an MRI, but it's also kind of nice having a CT because that's what you're going to be doing it with, Once I do the scout, kind of map out where I'm going to go. It's interesting. I was actually trained with New Wave, but I've kind of switched over pretty much exclusively now to Imprint. I like the single probe. I just like that. I think it's a little bit easier.
All right, so explain that to me. So why are you guaranteed to use a single probe versus what you're doing with New Wave where you might use multiple? I don't have any experience with Imprint, and so I just kind of want to hear what that switch has been like for you and how it's different.
Yeah, absolutely. So with Imprint, it's kind of nice because it's a single probe and the ablation zone is a little bit more spherical. Now, there's nothing that's going to be like a perfect circle, right? But in terms of spherical versus like, hot dog shaped is what I call it. The New Wave, it's very good at what it does, but I think one of the kind of challenges is that sometimes you need multiple probes. I would argue multiple times you need multiple probes, which, the benefit of that is you can overlap. But one of the nice things that I found with Imprint is a lot of times you don't need that overlapping kind of zone because it's kind of forming a more spherical burn. And because of kind of how wide it can get, it can even go up to 4 and change. I don't remember exactly, but which is kind of way beyond what you need. So if you kind of go right in the middle and shish kebab it, as I say, you should be able to kind of cover the entire tumor with one burn. And then, I always track the blade back. So that's another thing I like with Imprint.